Hello, today I'm going to tell you the quickest way to diagnose anemia in a patient who comes to the clinic. Anemia is, is defined as a hemoglobin level of less than 10.5. But anything less than 11.5 may be symptomatic. Therefore, arbitrarily, I often investigate people who have unexplained hemoglobin of less than 11.5. If you get a blood picture with low hemoglobin, always look for the other cell lines. You need to look at the WBC count and the platelets. If the WBC count, the hemoglobin, and the platelets are low, this is defined as pancytopenia. And pancytopenia means that there is something wrong with the bone marrow. And if something is wrong with the bone marrow, this could either be because of infiltration. That means there is CA or granulomatous diseases, for instance, lupus. Or there could be a drug toxicity. Many drugs, including antibiotics, painkillers, and lots of other drugs, they can cause pancytopenia by affecting the bone marrow. And the third one is it could be because of infection. An infection, it could be in the form of septicemia, or it can just plain simple be pneumonia for that purpose. If the patient has normal WBC count and normal platelet count, but the patient has got a low hemoglobin, the next step is to look at the MCV. Now, the MCV defines what kind of anemia there is. We've got three possibilities with an MCV. Either we have a normal MCV, which is 80 to 96, we have an MCV of greater than 100, or we have an MCV or less than 76. An MCV of 80 to 96 means that these are normocytes or cells which have got a normal size. An MCV of greater than 100 means they are macrocyte. And an MCV of less than 76 means that these are microcytes. If you've got microcytes in your blood picture, but you haven't got anemia, then this is microcytosis without anemia. So therefore, it will not be labeled as microcytic anemia. For it to be labeled as microcytic anemia, you must have a low hemoglobin level as well. There are certain conditions in which you can get increased MCV, in other words, macrocytes, but without anemia. And these include pregnancy, hereditary spherocytosis, liver disease, alcohol abuse, reticulocytosis, and aplasia of the bone marrow. And these are the conditions in which you will get macrocytes. You may get macrocytes, in fact, but without getting anemia. As far as normocytes are concerned, you can get low hemoglobin and it be called at normochromic normocytic anemia. The reason I say is normochromic is because the MCH and MCHC, they are normal. And this is often called as anemia of chronic disease. So anemia of chronic disease, and any chronic disease can cause it. For example, chronic kidney disease, chronic liver disease, chronic congestive heart failure. You've got chronic lupus, chronic rheumatoid arthritis. So any of the chronic diseases, they can cause this kind of anemia. But often normochromic normocytic anemia, it goes along with microcytic anemia. Now, if you've got microcytes with an MCV of less than 76 and the HP count is less than 10.5, this means that either the patient has got iron deficiency anemia or one of the other kinds of microcytic anemia. So the next step is to look for serum iron, ferritin, and TIBC. Serum iron and ferritin together, if you use an equation, then this leads to transferrin saturation. Normally, what we want is transferrin saturation to be greater than 16. And what transferrin saturation really means is that transferrin is the carrier protein which takes iron from the stores, which are usually in the GI tract, and then it transfers that iron to the liver and also to the bone marrow. So if the transferrin proteins are not saturated, it means that either transferrin level is low, the protein count is low, or the iron is less. And if the transferrin saturation is high, that means that you got adequate amounts of iron on board. Ferritin, on the other hand, it tells you about the iron stores, but ferritin we know is an acute phase protein and can fluctuate. And hence, it's always wise to check for the transferrin saturation based on iron and TIPC. If iron is low, ferritin is low, and TIBC is high, then this is called as iron deficiency anemia. And iron deficiency anemia, we know, is most commonly because of blood loss. 98% of all iron in the body is recycled, and most of that recycling it takes place when in the macrophages, the iron gets stored. So in iron deficiency anemia, there's loss of iron. This is usually from the GI tract in postmenopausal women and in elderly people. In premenopausal women, it is often because of menstrual blood loss. In one menstrual cycle, about 30 to 50 ml of blood is lost, which is all right. But if a woman loses about 100 ml of blood per cycle in 3 cycles, she will become iron deficient. If, on the other hand, iron levels are normal, ferritin level is high, and TIBC is low or normal, then this could either be thalassemia or it could be sideroblastic anemia. Remember, in sideroblastic anemia, you will get microcytes. Thalassemia, there is no treatment. It's a congenital condition. As far as sideroblastic anemia is concerned, this often means that there is an underlying cause, usually a chronic illness like malignancy or any of the underlying illnesses in which the patient has developed sideroblast. That means you've got adequate amounts of iron, you've got everything available, but they're just not being incorporated in the red cells to prevent anemia. So hence you've got a brief summary of how to approach a patient with anemia. First of all, make sure that the patient is anemic with a hemoglobin less than 10.5. Look at the other cell lines, whether there's pancytopenia or not. If there's pancytopenia, forget all of these, go straight to bone marrow. Find the underlying cause. Often what you'll find in a clinic, or often what you'll find even in hospital patients, is drug toxicity, which is the commonest one. And if the cell lines are fine, look at the MCV on a blood report. Um, Define what the MCV is: microcytes, normocytes, or macrocytes. And this obviously is with anemia. If there is no anemia, but you've got larger cells, then it's one of these conditions. And if you've got anemia with normocytes, then it's one of the chronic illnesses. But usually, most commonly, what we see is microcytes, and there's microcytic anemia, and that's usually because of iron deficiency, or it can be because of sideroblastic anemia. Thank you. Hello, this is another video which is in relation to anemia, which I've done earlier on. I have a patient here who's been suffering from symptomatic anemia for the last 4 years, and she has been to numerous doctors, has had numerous investigations, and every time the hemoglobin level was found to be around 8. As you can see in this report, the hemoglobin is 8, and I've got several other reports from before in which the hemoglobin was more or less in the same range. And this patient has been extensively investigated, and she has been given iron on numerous occasions, and every time iron was given, the hemoglobin, it reached a maximum height of about 11, but never beyond that. If you can see clearly, in this report, you've got an MCV value of 64.6. Now, if you recall, in my previous video, what I mentioned was if the MCV is less than 76, then it denotes that there is microcytosis. So we do have confirmatory evidence that there is microcytosis. But along with that, and this is a report from before, same thing and same microcytosis you can see. Now, Along with that, so this was microcytic anemia, but a very important report that was done quite recently, which was a ferritin level of in excess of 1400. So this patient has anemia, she's got microcytosis, but she's got a high ferritin level, a TIBC value of 235, and an LDH value of 258. So with high ferritin level and a low hemoglobin with a low MCV, this means that iron is present in abundance in the body and is not been incorporated in the red cells. So she will not have a hemoglobin above 11 and falls in the category of either sideroblastic anemia or falls under thalassemia. The reason I'm not pressing on sideroblastic anemia because the history is for the last 4 years, and if she had any underlying significant medical conditions, they would have shown so far. These are the medications she's taking. She's taking one for her diabetes, one for her blood pressure, and she's also taking one for her stomach. Now she's actually on a PPI for more than 4 years. We know PPIs can prevent iron absorption, and likewise we've got valsartan, which can cause pancytopenia, and then she's also got metformin, which we know can cause problems with vitamin B12 absorption. So in summary, she has got high ferritin, low hemoglobin count, high levels of iron, and a TIBC of less than the normal value, and she falls under the category of thalassemia minor. If she had thalassemia major, the hemoglobin would be less than 7. For thalassemia trait, it would be about 11ish. But this is thalassemia minor. She does not need any treatment as there is none. Thank you.